Welcome to University of Reproductive Associates IVF Orientation. This video is intended to provide background information and specific details for any patient involved in an in vitro fertilization cycle using either their own eggs or donor eggs. Our goal is to help you understand the IVF process from beginning to end and to answer questions that virtually all patients have when starting on this exciting journey. My name is Dr. Adam Fechner, and I am one of the attending physicians at URA, along with Drs. Michael Cho, Nataki Douglas, Jacqueline Laughlin, Sarah Morelli, Kavitha Prasad, Susan Wolf, and Peter McGovern, who you will be hearing from in the second half of this orientation video. Any day you come to the office for a procedure, including most ultrasounds, you will see one of the doctors here. Please keep in mind that we take a team approach at URA, but your doctor is ultimately the one managing your cycle. So while you may be seeing other physicians on a regular basis, we are all constantly communicating with each other regarding your care. Because the timing of the egg retrieval and embryo transfer depend on your response to the medications, they will be performed by whichever doctor is covering the office that day. In some cases, that turns out to be your doctor, but in many cases, your doctor will not be performing these procedures. They will, however, be closely following your progress throughout the entire IVF process. Over the course of this orientation, we will review what IVF is and why a patient would do IVF. We'll talk about the steps necessary to get ready for your IVF cycle, and we will provide a summary of a sample IVF cycle. We will review some very important information about the IVF fertility medications you will use, and we will discuss what happens with your eggs, sperm, and embryos in the IVF laboratory. Finally, we will discuss pre-implantation genetic testing. Before we get into the details of IVF, it is helpful to review the physiology of natural conception. During the menstrual cycle, an egg is released from the ovary, which is called ovulation, and enters the fallopian tube. With intercourse, sperm is deposited in the vagina and has to swim up through the cervix, through the uterus, and into the fallopian tube from the opposite direction. The sperm and egg come together in the tube, a process called fertilization, and the resulting embryo then travels to the uterus where it implants and the baby grows. For the general fertile population, the chance of any 1 month resulting in a pregnancy is approximately 20%. With IVF, this coming together of the sperm and egg occurs not in the fallopian tube, but in a dish in the laboratory. The example you see here is a patient with blocked tubes, so the sperm and egg can't get together on their own. In this case, the woman would take injectable fertility drugs, which stimulate the ovary to produce multiple eggs, each of which is in a fluid-filled follicle. When the follicles are large enough and the eggs are mature, she would then undergo a surgical egg retrieval, which you see here. This procedure is typically performed under anesthesia, so the patient is asleep and does not feel any pain. A thin needle is passed through the vagina and into each of these fluid-filled sacs. The fluid from each follicle is aspirated into a test tube and given to our embryologist, who looks at this fluid under a microscope, finds the eggs, and separates them out. Later that same day, the sperm and eggs will be brought together in a process called insemination. We will discuss this process in more detail shortly. If planning a fresh embryo transfer, 1 or more embryos will be passed back into the uterine cavity 5 days after the egg retrieval. If a patient is undergoing an egg freezing cycle, the eggs would be frozen on the day of the retrieval without inseminating them with sperm, and the cycle would be complete. So why would a patient do IVF? In the case of tubal factor infertility, if the fallopian tubes are blocked, there is no other way for the sperm and egg to come together, so IVF is necessary. In cases of male factor infertility, where the sperm count is very low or the shape is severely abnormal, IVF provides the best option to achieve fertilization. In cases of unexplained infertility, or if a patient has tried other treatment options that have been unsuccessful, IVF would be the next best step to achieve conception. If a patient is using an egg donor or a gestational carrier, or if they are planning to freeze their eggs for fertility preservation, IVF is necessary. And finally, in cases where we want to perform pre-implantation genetic testing of embryos to test them for specific genetic conditions or general chromosomal abnormalities, IVF must be performed so we can biopsy the embryos in the lab. So what are the benefits of IVF? As we mentioned, IVF can overcome severe tubal factor and malfactor infertility where pregnancy may not otherwise occur through natural conception or other treatments like intrauterine insemination. IVF offers the highest possible chance of conception, and because we can control how many embryos we put back into the uterus, we can minimize the risk of multiple births. Because we observe the embryos in the laboratory, IVF provides a lot of helpful information about sperm, egg, and embryo quality that we would not get from other types of treatment. And finally, because we have access to the embryos, we can biopsy them to perform pre-implantation genetic testing. This next slide presents a concept that is critical for you to understand: the question of what happens to your eggs throughout the IVF process. Unfortunately, as you can see here, there is a drop-off at every step of the process. Not every follicle we see on ultrasound will contain an egg. Not all eggs that we retrieve are mature or will fertilize normally. Of those that do fertilize normally, not all of them will develop into embryos that we can transfer. And of course, not all of the embryos we transfer will necessarily result in pregnancy. So for example, if we retrieve 10 eggs from an average woman, we expect about 6 to 7 of them will fertilize normally, 4 or 5 of these will develop to day 3, 3 or 4 will develop to day 5, and if we are lucky, 1 or 2 of them will implant, hopefully resulting in a live-born baby. It is completely normal to drop from having a fairly large number of eggs retrieved, 10 or more, to having only a few embryos available for transfer. This is a normal part of the process. The tremendous loss rate for both eggs and sperm is a normal part of human reproduction, and the reason even couples at peak fertility only have a 15 to 20% chance of pregnancy in any given month, as the number of eggs we retrieve, as well as the quality of these eggs, depends in large part on the woman's age. The process of pre-implantation genetic testing, or PGT, allows us to check the number of chromosomes in each embryo. This testing has revealed that, even for women under 40 years old, approximately 50% of embryos will be abnormal. This percentage increases to over 75% abnormal embryos as a woman gets into her early 40s. So even when there are quote-unquote normal-appearing embryos available, there is a significant chance, at least 50 to 75%, that they are actually abnormal and will not result in a healthy baby. It then becomes clear why we aim for as many eggs as possible without overstimulating you, because the more eggs we start with, the better the chances of having good quality embryos to transfer and possibly to freeze if we have excess embryos. Like most other medical treatments, IVF is not completely without risks, so we will spend the next few slides talking about what can go wrong during the process. A woman may have a poor response to the fertility drugs and not make as many eggs as we would expect, and in certain cases may not respond at all. Only 5% or less of IVF cycles are actually canceled, and this typically occurs only when 2 or fewer mature follicles develop. But as many as 20 to 30% of IVF cycles can be complicated by a lower response to medications than expected, and in many cases this cannot be predicted based upon the pre-IVF testing results. The eggs that we do get may not fertilize well, or they may fertilize but the embryos develop poorly. Of course, IVF may not result in pregnancy, or you may get pregnant but ultimately experience a miscarriage. Or it's possible to carry the pregnancy and deliver a baby, but that child may not be completely healthy. The short-term risks associated with IVF are mostly related to the fertility drugs or the surgical procedure we perform to obtain the eggs. This egg retrieval is associated with a small risk of pelvic infection that occurs in approximately 1 out of every 200 patients. We are passing a needle into the ovary, so there is also a small chance of bleeding from the ovary or damage to the other organs in the pelvis, like the uterus, the intestines, the bladder, or blood vessels. These complications thankfully are rare and occur only in 1 out of every 1,000 cases. In response to the fertility drugs, the ovaries can become quite enlarged and heavy, and in rare cases, they can twist around and cut off their own blood supply, a condition known as ovarian torsion. This is a surgical emergency and requires surgery to untwist the ovary as soon as possible in the unlikely event that it does occur. In some cases, the ovaries can become overstimulated, a condition known as ovarian hyperstimulation syndrome, or OHSS. About 10% of women going through IVF experience a mild case of OHSS, which mainly presents as some bloating and cramping. Severe cases, which occur about once every 200 patients, involve fluid accumulating in the belly and in very severe cases in the lungs. This can require hospitalization for supportive management like IV fluids and blood thinners to help prevent blood clots, and in some cases requires passing a small needle into the abdomen to help drain off some of the fluid. The condition resolves by itself over the course of several days to a week or more, but can be prolonged if you do become pregnant. We list multiple pregnancy, twins or triplets or more, as a complication because we do aim for one baby at a time. Overall, the risk of twins with IVF is around 27% if we transfer more than one embryo back into the uterus. Triplets occur around 1% of the time and can occur even if we only transfer 2 embryos, as one or both could possibly split. This is called identical or monozygotic twinning. These twins can have connected placental blood vessels, or in very rare cases, an actual attachment of the babies, which is known as conjoined twins, and therefore have much greater obstetrical and neonatal problems as compared to fraternal or non-identical twins, which is the more common scenario. Most of the risks of multiple births can be avoided with the use of elective single embryo transfer, in which only one embryo is transferred. In this case, the risk of twins is less than 1%, and almost all of the pregnancies are singletons. Many patients elect to perform pre-implantation genetic testing of their embryos so we can determine which embryo will provide the best chance of pregnancy during an elective single embryo transfer. Finally, there is an increased risk of an ectopic pregnancy, or a pregnancy outside of the uterus, when a woman undergoes IVF. Most commonly, this pregnancy attaches in the fallopian tube, but more rarely can occur in the cervix or the corner of the uterus, among other places. This risk is under 5% in women with normal fallopian tubes, but can be as high as 10% in women with damaged tubes. The risk of ectopic pregnancy is one of the reasons that we advise women with large, dilated, and damaged fallopian tubes, known as a hydrosalpinx, to undergo surgical removal or clipping prior to IVF. With all IVF pregnancies, we follow you very closely with early blood work and ultrasound, so if a pregnancy is not in the correct place, we usually know about it early enough to treat it with medication rather than surgery. However, surgery is sometimes necessary to remove the pregnancy tissue, or in some cases, the entire fallopian tube. There are some long-term risks that are associated with IVF, like the possibility that adhesions or scar tissue develop around the ovaries following the egg retrieval. This occurs less than 1% of the time, but could possibly impair future fertility. One question patients have is whether the use of fertility drugs increases the risk of ovarian cancer. Previous studies found an increased risk of ovarian cancer in association with these medications. However, these studies were not performed with the proper control group. When the studies were redone correctly, there was no increased risk of ovarian cancer in patients using these drugs. The only cancer risk which has been reported at this point seems to be a slightly increased risk of borderline ovarian tumors, also known as tumors of low malignant potential. These are typically ovarian cancers with a relatively good prognosis, and there is some argument as to whether some of them may have been present as ovarian cysts before the fertility drugs were used, but this is still unclear. We know there is a greater risk of ovarian cancer in women who have few or no pregnancies, and therefore the infertile population in general is at greater risk. It is very well established that the use of birth control pills for 10 years will cut your risk of ovarian cancer in half, so this may be a good option for those concerned by the data showing a possible link between fertility drugs and borderline ovarian tumors. The other common question is whether IVF will make a woman go into menopause early, since we are taking more eggs than she would typically make that month. But this is not the case. For anyone who has undergone an ultrasound and blood work on day 3 of your cycle, you may have noticed the doctor count the number of antral or small follicles on the ovaries. This is the group of eggs that you have to work with that month. Of these, one will grow and ultimately ovulate, and the others will die out and undergo a process known as atresia. Then the next month there is another group to choose from. So for example, if you have 10 antral follicles on day 3, one will develop and ovulate, the other 9 will undergo atresia. With IVF, we are trying to get as many of those other 9 eggs to develop as possible so we can retrieve them. Therefore, we are not retrieving any eggs that you weren't already going to lose that month. Patients are understandably concerned about the possible risks of IVF on the resultant child. However, there is very little evidence to suggest that children born after IVF exhibit any significant impairments compared to children conceived spontaneously. The majority of studies suggest normal growth, development, and social adjustment in these children. We do have evidence that under certain circumstances, a procedure known as intracytoplasmic sperm injection, or ICSI, is associated with a small increased risk of genetic abnormalities. This technique, which you will see a video of shortly, involves injecting a single sperm into each egg, and when it is performed using sperm from men who have a very low sperm count, is associated with a less than 1% increased risk of genetic problems. These problems most commonly involve the sex chromosomes, and it is unclear whether the increased risk is due to the procedure itself or to some underlying issue with the sperm, since we are fertilizing eggs with sperm that otherwise may not have been able to achieve pregnancy without our help. Patients also often ask whether IVF increases the risk of birth defects. The majority of studies show no large increase in birth defect risk after IVF, but in some studies the risk may be up to 1/3 higher. The background risk of birth defects is about 4 to 5% in the general population, so with IVF we are at most talking about an absolute increased risk of 1 to 2%. The problem in understanding this issue is that most of the studies done to date have compared a younger, fertile population with an older, infertile group. This makes it difficult to determine how much of the risk is due to the infertility itself and how much is due to the treatment of the infertility. One large, well-done study of over 3,000 births found a 5% rate of birth defects in fertile couples, a 6% incidence in infertile couples who ultimately conceived naturally, and this group included Clomid and IUI pregnancies, and a 6.7% rate in couples who underwent IVF. So again, the question is raised of whether it is the technique or the underlying infertility that increases certain risks. In any event, the absolute increase in risk is small at best, but is certainly worth mentioning. Now that we've discussed the risks of IVF, let's talk about what you need to do in order to prepare for your cycle. We have a checklist of blood work and other procedures that must be completed before starting your stimulation medications. We will review these in the next slide. It is very important to optimize any chronic medical problems like high blood pressure, thyroid disease, or diabetes before starting your cycle. This will ensure you are in the best health possible and will give you the best chance not only of getting pregnant, but of having a healthy pregnancy. If you smoke, you must talk to your doctor about nicotine replacement or other aids to smoking cessation before your IVF cycle. Smokers have half the IVF success rate of non-smokers, so smoking during your IVF cycle may be one of the absolute worst decisions it is possible to make. Our financial counselors will investigate whether your insurance covers IVF and will get the proper authorization. For those whose insurance will not cover any or all of your IVF cycle, they will also clearly explain what your out-of-pocket costs will be and what your options are in case you need help financing some or all of your cycle. Our nurses and IVF coordinators will help you get ready for your cycle and will communicate with you at every step along the way. We strongly urge you to keep in touch with us and, most importantly, to ask questions anytime you are not sure of your next step. The timeline provided in your IVF packet outlines the items on the checklist. There is blood work that must be performed on both you and your partner, if applicable. Your pap smear and cervical cultures must be up to date and will be repeated as necessary. In order to ensure the uterus is normal in preparation for an embryo transfer, we will perform either a hysteroscopy or a hydrosonogram to evaluate the uterine cavity. Both procedures are typically performed without anesthesia and are associated with only minimal discomfort. The hysteroscopy involves passing a very thin camera into the uterus and looking at the images on a TV screen. The hydrosonogram involves passing a very thin catheter into the uterus and performing an ultrasound while we gently push sterile water into the uterine cavity. These procedures are performed to make sure there is nothing inside the uterus, like fibroids or scar tissue, that could impair the ability of the embryos to take hold and implant. At the same time, we perform a mock embryo transfer to test the depth and curve of the uterus. This is like a dry run for the actual embryo transfer that typically takes place after the egg retrieval. If using partner sperm for IVF, The male partner must have undergone 2 semen analyses within the past year, so we know how best to inseminate the eggs on the day of the retrieval. Education is a critical component of a successful IVF cycle. Every patient undergoing IVF must watch online videos to learn about the fertility drugs and how to properly inject them. There may be additional testing your doctor asks you to perform in addition to these items on the checklist, and if any underlying anatomic abnormalities are found, he or she may recommend performing surgery prior to starting your cycle. Financial clearance must be obtained. Whether you are using insurance or paying out of pocket for services, arrangements must be made prior to starting the IVF cycle. Finally, once the entire checklist is complete, you must attend a final IVF go visit with your doctor, at which time you will review all of the final preparations for your cycle and review the medications with the nurse. The IVF protocol, or the way in which we stimulate your ovaries, is customized for each individual patient. Your doctor decides the type of protocol and the specific medication doses based on the results of your testing and other circumstances, such as your age and any underlying conditions. Although the protocols differ as to the specific order of events, every IVF protocol involves 2 phases: suppressing your natural cycle and stimulating the ovaries to produce multiple eggs. With ovarian stimulation, your hormone levels can become much higher than usual, putting you at risk of ovulating early. If you were to ovulate early, we would not be able to retrieve your eggs and the cycle would have to be canceled. Therefore, it is very important for us to suppress your natural cycle so we can trigger ovulation only when the ovaries are ready. Many of you will be following the antagonist protocol, which typically begins with you taking 2 to 3 weeks of an oral medication, either a birth control pill or a progestin-only pill known as norethindrone acetate. These pills suppress the ovaries, getting them ready to respond to the injectable fertility medications. Others will be on the long protocol, in which case we use an injectable medication called Lupron for suppression. Regardless of the suppression protocol, in no case will any stimulating drugs be started until after your checklist is complete, you have attended your go visit, and you have had a baseline ultrasound and blood work confirming your ovaries are ready to start the stimulation medication. There are benefits to each of these approaches under different circumstances, and your doctor can discuss the details as well as why he or she chose a particular protocol at the time of your go visit. For women with diminished ovarian function, traditional IVF may not be the best option. This is because of the drop-off at every step of the process. As we discussed earlier, we may start with 10 eggs and only have 3 or 4 embryos that survive to day 5. If the ovaries are not functioning well, we may only get 2 or 3 eggs to start with, so at the end of the entire cycle, there may not be any embryos that survive to transfer. In this case, your doctor may recommend the use of donor eggs. In egg donation, the retrieval of eggs from the donor is typically a separate process from the embryo transfer into your uterus. The retrieval may have taken place a while ago, as in the case of frozen donor eggs from an egg bank, or it may take place in a coordinated fresh egg retrieval process. In this case, oral contraceptive tablets or birth control pills may be used to synchronize both women's menstrual cycles so that the recipient's uterus can be prepared to be ready when the donor's eggs are available. We will not get into the details here, but if a fresh donor is being used, she ultimately undergoes ovarian stimulation similar to our other patients at the same time we are preparing the recipient's uterus to receive the embryos. There are benefits to each of these approaches under different circumstances, and your doctor can discuss the details as well as why he or she chose a particular protocol at the time of your go visit. After all of the preparatory procedures are complete and ovarian suppression has been achieved, you will then begin the injectable fertility drugs, usually on a Friday or Saturday evening, and will take them until the follicles are large enough and the eggs are ready to be retrieved. Most patients require stimulation medication for approximately 8 to 10 days, but patients may be on these medications for as few as 7 or as many as 14 days. During this time, you will be monitored closely with blood work and ultrasound. Monitoring is performed in the mornings at one of our offices, and when the cycle starts, you may be coming in every 2 to 3 days. As you get closer to the end of your cycle, however, you may be coming to the office every morning. We do this because your medication may need adjustments on a regular basis as we try to strike a balance between getting as many eggs as possible without overstimulating the ovaries. Once the follicles are large enough, you will take an injection to trigger their final maturation, and we will perform the egg retrieval about 34 hours later. If you are using fresh sperm from your partner, he must produce a specimen the same day as the egg retrieval. We will discuss this in more detail in several slides. The embryologist then puts the sperm and egg together in a dish, and the embryo transfer occurs 5 days later. This calendar shows you a sample IVF cycle. Please keep in mind this is only an example, and your cycle will not be identical to this. This patient would have already been taking either birth control pills or Lupron to suppress her natural cycle for at least a week prior to this point in the calendar. Once her checklist has been completed and she is ready to go, she will come for baseline testing, which in this example is on a Wednesday. She will then be given instructions to start her injectable stimulation medications, or gonadotropins, that same Friday. She would take the medication for 3 nights, then would return Monday for blood work and ultrasound. Based on those results, we may tell her to adjust her dose up or down, or to continue the same dose, and in this case, instruct her to return Wednesday for monitoring again. We will again perform an ultrasound and blood work, and based on those results, we will again give her instructions as to her next steps, which involves returning again after 2 more nights of medication. On Friday, we see that she is close to being ready, so we may have her come back the next day. On Saturday, she is not quite ready, so we have her return Sunday, at which point the ultrasound and blood work show she is ready to be triggered for the egg retrieval. We will give her very detailed instructions for taking her HCG injection Sunday night, including the exact time to take the shot and a reminder for how to mix and administer the medication. She returns the following morning for a blood test to confirm she absorbed the medication, then is given instructions for the egg retrieval the following day, in this case on a Tuesday. If this is an IVF cycle, the eggs will be inseminated with sperm later that same day, and if a fresh embryo transfer is planned, it would take place 5 days later. Please note we count the day of the egg retrieval as day 0. If this is an egg freezing cycle, the eggs will be frozen the day of the retrieval and the cycle would be complete. If the plan is to perform pre-implantation genetic testing on the embryos, they would be biopsied on day 5, 6, or 7, then would be frozen the same day. For all IVF cycles in which we are freezing excess or biopsied embryos, they would be frozen on day 6 after the retrieval, in this example on Tuesday. The morning monitoring visits, when you come for ultrasound and/or blood work during your cycle, is from 7 to 8 a.m. every morning at the Hasbrouck Heights office. This office is open every single day of the year, including weekends and holidays, and is the default office for all monitoring. We also offer monitoring at our Hoboken office from 7 to 8 a.m. Monday through Friday, and at our Wayne office from 7 to 8 a.m. Monday through Thursday. If you are monitored at the Hoboken or Wayne office during the week, you will have to come to Hasbrouck Heights if a monitoring day falls on the weekend. The monitoring schedule for all 3 locations can be found on our website at www.uranj.com. During your IVF cycle, you will have blood work and a transvaginal ultrasound performed at each visit. Every day that you come for morning monitoring, you will receive detailed instructions with your next steps. These instructions will be available by the late afternoon that same day once your doctor has reviewed your blood work results and ultrasound findings. We predominantly communicate these instructions through our eIVF patient portal, which is the way you can access your records in our electronic medical system. You can find a link to the portal at the top of our webpage. You should have received your username when you registered as a new patient, but if you cannot remember your username, please contact the front desk staff. They can also perform a password reset if you are unable to do so in the system itself. Please note eIVF also has a mobile app you can download for your phone or tablet. To do this, follow the instructions on the main page when you log into the portal through our website. Once you are logged into the patient portal, you will be able to see your instructions, including which medications to take and when to return for further monitoring. In some cases, you may also receive a phone call from a nurse to review your instructions. We typically will call you if your instructions require some additional explanation or when the instructions are critically important. For example, when we give instructions for the HCG trigger, we must speak to you directly to make sure you understand your instructions. In any event, you should receive your instructions by 5:30 p.m. the same day you were in the office. Please provide at least 2 working phone numbers, and more if possible, and please empty your voicemail box so we can leave you a message with your instructions if necessary. Medication doses or other instructions can change on a day-to-day basis, so if we cannot get in touch with you, it could jeopardize your entire cycle. Please do not call the office before 5:30 p.m. saying you did not receive instructions. If you have not received instructions through the portal or a phone call, please check your voicemail to make sure we didn't leave you a message. If 5:30 comes and you have still not received your instructions through the portal, call the main office number and tell the answering service that you need to speak to the doctor on call. Even though it's not true, tell them that you are bleeding in early pregnancy and they will page the doctor on call. We give you permission to lie in this one instance. The doctor will call you back shortly with your instructions. Your medication will be ordered for you by the nurse and will either be shipped to your home or you can pick it up at one of the specialty pharmacies. Your regular pharmacy will not carry these medications, so we ask that you use a specialty pharmacy from our list. These pharmacies are experts in fertility medications, and some of the local specialty pharmacies are open 7 days a week, so we can get you medication on short notice in case of emergency. Insurances that require prior authorization for medications, or those who require you to use a mail order pharmacy, require you to be extremely proactive since it can take several days to receive and process an order. You therefore need to stay on top of your medication supply and notify us if you suspect you may be running low. It is impossible to predict how much medication a woman will need for her IVF cycle. This means that some women may have extra medication at the end of her cycle, and others may need to get several refills during the cycle in order to make it to her egg retrieval. If we don't have enough notice to get insurance authorization or medication shipped, you may need to forego using your mail order pharmacy and instead pay out of pocket to get medications from a local specialty pharmacy. When you receive your medication, please review the packing slip and make sure they sent you everything on the list. Have your medication receipts available at the time of your go visit so the nurse can review them with you. You also must make sure you understand how to mix and administer all of the medication. The nurses will show you where to find online videos to teach you the proper techniques for administering the medication. If you still have any questions after watching the videos, you can review with the nurse at the time of the go visit. Please make sure you have enough medication to last you through weekends or holidays, and let us know when you are approximately halfway through your supply of meds. After several days of stimulation, the doctor should be able to give you an estimate of how many more days of medication you will require. Keep in mind, this is only an estimate. Since your dose may increase during a cycle, you may run out of medication before anticipated. You cannot skip a day of medication without damaging your cycle, so please make sure you have an adequate supply at all times. The timing of the medication is equally important, so you must take it as prescribed. Timing is flexible within 1 to 2 hours for most medications, so for example, 7 p.m. gives you a range of 5 to 9 p.m. Whatever time within that range works for you is okay, but we ask you to try to be consistent from day to day. However, the timed HCG trigger is the one medication that must be given at the exact time instructed and must be given exactly 34 hours prior to the egg retrieval. Most IVF cases are done in the morning, so the time for the HCG trigger shot is usually between 11 p.m. and 2 a.m. The nurse will give you very explicit instructions for the night of the HCG shot, and it must be administered at the specified time. A few minutes early or late is okay, but taking the shot significantly earlier or later than instructed can compromise the egg retrieval and ruin your cycle. The egg retrieval is a surgical procedure and will be performed by the doctor of the day in either the Hasbrouck Heights office or in Hasbrouck Heights Surgery Center, which is on the first floor of the same office building. You will be under anesthesia, so you cannot have anything to eat or drink after midnight the night before. The only exception is if we tell you to take certain medications, for example blood pressure or thyroid medicine, with a sip of water. This is very important because some patients become nauseous during anesthesia, and if your stomach is full of food and you vomit, there is a risk that you will aspirate those gastric contents and develop a very serious pneumonia. The majority of patients do not need to be intubated for the egg retrieval. This means you will be breathing on your own during the procedure, but you will be completely asleep, so you will not be moving or feeling any pain.
My name is Dr. Peter McGovern. I'm an attending physician at University Reproductive Associates, and I'll be narrating the second half of the IVF orientation presentation. So what happens in the IVF laboratory? The day of the egg retrieval, the embryologist finds the oocytes or eggs and prepares the sperm for insemination, which is performed later that same day. The embryologist monitors the development of the embryos and in certain cases performs assisted hatching or embryo biopsy, which we will discuss shortly. If the plan is for a fresh embryo transfer, they then prepare the embryos for transfer back into the uterus. If the plan is for embryo biopsy for genetic testing, this is usually done 5 to 6 days after the egg retrieval, and then the embryos are frozen until the test results come back. Finally, the embryologist can cryopreserve or freeze any remaining good quality embryos if you have decided to do so. The physician performing your egg retrieval aspirates the fluid from each of the follicles. The tiny oocyte or egg is in a very large volume of fluid, so the embryologist has to find each egg, rinse it, and place it into culture medium in a labeled dish. The sperm is then prepared for insemination, which is typically performed later the same day as the egg retrieval. Regardless of the source of sperm, we must have the sperm available at URA on the day of the retrieval. If you are using fresh sperm from your partner, he must come with you at the time of your retrieval to provide a sperm sample. If you are using frozen sperm from a donor or your partner, we need confirmation that the sperm has been received by our lab prior to starting your IVF cycle. Everything in the lab is meticulously labeled, so there is no confusion over which sample to use. Once the semen is received or thawed, the sperm is separated from the seminal fluid and delivered to the embryology lab where it is used to inseminate the eggs. A cycle can be adversely affected if there is no sperm available on the day of the retrieval. If there is even the smallest possibility that a man may not be able to produce a fresh sperm specimen on the day of the retrieval, you must talk to your doctor about freezing a backup sperm sample. That way we know some sperm is available in the event of a collection problem or unexpected travel. Who should freeze sperm as a backup? A man should strongly consider freezing if he has erectile dysfunction, performance anxiety, or any other condition that may make it difficult for him to physically produce a specimen when necessary. If there is the possibility of unanticipated travel around the time of the egg retrieval, we strongly recommend freezing as a backup. If the sperm is being collected through any method other than masturbation, for example, if it is being retrieved surgically from the testes by a urologist, or if you and your wife are having intercourse with a special non-spermicidal condom called a male factor pack to obtain your sample, then the sperm must be frozen beforehand. If you have any questions about whether you should freeze sperm, please talk to your doctor to discuss further. Remember, we need both eggs and sperm to get you a child. Once the eggs have been retrieved and the sperm is in the lab, the two must be brought together in order for fertilization to occur. This can be done either through standard insemination, in which many motile sperm are added to a dish with each oocyte and are left to fertilize the egg on their own, or the embryologist can inject one sperm into each mature egg, a process known as intracytoplasmic sperm injection, or ICSI. This procedure overcomes most fertilization problems and is the preferred method of choice in the event of ejaculated sperm with a poor prognosis, such as low morphology, or with surgically retrieved sperm which cannot fertilize eggs without extra help. This video demonstrates the ICSI procedure. On the right, you can see the oocyte being held in place by gentle suction. A single sperm has already been placed into this hollow needle, which is then inserted into the oocyte. The embryologist draws the sperm back along with some fluid and then injects the sperm directly into the egg. This process is repeated with all of the mature eggs that have been retrieved. The day after the egg retrieval, the embryologist assesses the embryos to determine how many have fertilized normally. The fertilized egg should demonstrate one pronucleus from the oocyte and one from the sperm, each of which should contain 23 chromosomes. Therefore, we expect 2 pronuclei and 46 chromosomes in each normally fertilized embryo. The day after the retrieval, you will receive a patient portal message or a direct phone call by the early afternoon, typically around 1 to 2 p.m., notifying you of how many eggs fertilized normally. These embryos are maintained in incubators at body temperature, and the embryologist periodically checks them to monitor their development. They specifically do not check them every day, as checking them requires removing them from the incubator, which may not be optimal for their chances of development. The lab tries, therefore, to only check them on day 1, day 3, and day 5 after egg retrieval. You will also receive final contact on day 7, 1 week after the egg retrieval, when we have the complete number of embryos which have been able to be biopsied and/or frozen and stored for future use. A normally fertilized egg should contain 2 pronuclei, but this does not guarantee a normal number of chromosomes, since it is possible that each pronucleus may contain too many or too few chromosomes. However, we know that an embryo containing any number of pronuclei other than 2 is definitely abnormal and cannot become a normal healthy baby. This can be caused by polyspermy, in which 2 or more sperm penetrate the same egg, typically only seen after standard insemination, or after fertilization of an abnormal egg, which has failed to reduce its number of chromosomes from 46 down to 23. This is usually the explanation when too many pronuclei are seen after ICSI. You can see here an embryo with 3 pronuclei, which would have 69 chromosomes, and this other one has 4 pronuclei with 92 chromosomes. These abnormal embryos will never result in a living child, so they are never transferred and are always discarded. On the day of embryo transfer, we assess the appearance of each embryo and grade it based on several factors. The details of this grading depend on whether the embryos are at the cleavage stage on day 3 after retrieval, or at the blastocyst stage, which is 5 days after retrieval. We prefer to perform the embryo transfer on day 5 whenever possible, because it gives us more time to observe the embryos to try to select the best ones. Under certain circumstances, your physician or the embryologist may recommend a day 3 transfer, but most patients will be advised to undergo transfer on day 5, as success rates are better with day 5 or blastocyst stage embryo transfer. This is what the embryos, now called blastocysts, look like on day 5. The inner mass of cells will become the baby itself, while the outer cells will develop into the placenta and other tissues. If an embryo biopsy is performed for pre-implantation genetic testing, as we will discuss shortly, a few of these outer cells are removed and sent for analysis, so we are not disturbing any cells destined to become the baby itself. If genetic testing is not being performed, the embryos are graded based on their level of development and their appearance. Without doing genetic testing, we cannot definitively tell if an embryo is normal or abnormal, so we choose the best embryos to transfer based upon their morphology or appearance. Embryo assessment is not an exact science, so please take all information on the day of transfer with a grain of salt. We have certainly seen poor quality embryos implant and become beautiful babies, while excellent quality embryos may not result in pregnancy. So we truly won't know till the pregnancy test whether the cycle has been successful. Depending on the circumstances of your particular case, your doctor may recommend performing assisted zona hatching, or AZH, on your embryos prior to the transfer. In order to successfully implant in the uterus, the embryo must first escape or hatch from its shell in order to directly contact the uterine lining. We can assist this escape by making a small hole in the shell, or zona pellucida, using a technique known as assisted hatching. This short video demonstrates how assisted zona hatching is performed. The embryologist uses a laser to make a small hole in the zona pellucida, or shell, surrounding the embryo. This technique can make it easier for the embryo to escape the zona pellucida and hopefully implant in the uterine lining. AZH is typically performed on day 3 of embryo development. At the time of your go visit, your doctor will discuss AZH with you and whether it is recommended in your particular case. After the oocytes have been retrieved and fertilized, and we have watched the embryos progress, it is time to return one or more of them to the reproductive tract, a procedure known as an embryo transfer. Unlike the egg retrieval, anesthesia is typically not necessary for the embryo transfer, as it only involves a speculum exam and the passage of a thin plastic catheter into the uterus. The procedure is performed under abdominal ultrasound guidance, so we can see exactly where the catheter is going. For this reason, the nurse will instruct you to have a full bladder at the time of the procedure so that we can get a better view of the uterus. The physician inserts an empty catheter into the uterus first to ensure proper placement. While this is happening, your embryos remain in the laboratory incubator. Once we are sure the catheter is in the correct location, the embryologist loads the embryo or embryos into another smaller catheter, which the physician carefully passes into the uterus through the first catheter. We confirm the proper placement of the catheter, after which the embryos are gently expelled into the uterus. You can see here a view of the uterus on transabdominal ultrasound, and here is the uterine lining where we are aiming to put the embryos. The embryos themselves are microscopic, but you will be able to see on ultrasound the small air bubbles that are packed on either side of the embryos. Whether we are transferring one or more than one embryo, they all go in together at the same time. Following the embryo transfer, you will be able to walk out of the transfer room immediately after the nurse has reviewed your explicit instructions on which medications to take and when to return for your pregnancy test. For most patients, we transfer the best 1 to 2 embryos and continue to observe any others that are continuing to progress. Only in extremely rare cases, with prior approval by the IVF team, will we ever transfer more than 2 embryos. This is because there is rarely, if ever, any improvement in the chances of becoming pregnant using more than 2 embryos, but there is a much greater risk of multiple pregnancy when more than 2 embryos are transferred in at one time. If you choose to undergo pre-implantation genetic testing, or PGT, you will have to freeze your embryos, as the genetic test results are not available in time for a fresh transfer that cycle. If you have excess embryos that are still developing and that look good following the embryo transfer, you have the option to freeze them for later use. Our embryology staff only recommends freezing good quality embryos, as these have the best chance of surviving the thaw and potentially resulting in pregnancy. If you have frozen embryos, you can undergo a frozen thawed embryo transfer, or FET, in a subsequent cycle. Ultimately, the more embryos you have frozen, the better the chances of success. If you choose not to freeze, any excess embryos you have will be discarded immediately after the fresh embryo transfer. What are the benefits of freezing embryos? You may make more embryos than you or your doctors expect, so we ask all patients in advance whether they want to freeze their excess embryos. In the best case scenario, you get pregnant from your IVF cycle and have a healthy baby 9 months later. If you have frozen embryos, you have an opportunity for another pregnancy from the same IVF cycle and can do an FET cycle without having to take all of the injectable fertility drugs, undergo anesthesia and the egg retrieval, etc. If your first IVF cycle is unsuccessful but you have frozen embryos, you can go right into an FET cycle and try again for pregnancy without having to repeat the full IVF cycle. The success rate of an FET cycle depends on the age of the woman at which the embryos were frozen, not her age at the time that they are thawed and transferred. So if you get pregnant at age 35 from a fresh IVF cycle and return 5 years later to transfer your excess embryos, the chance of success is that of a 35-year-old, not a 40-year-old. The chance of miscarriage is also decreased, since the risk of chromosome problems depends on the age at which the embryos are frozen, not when they are thawed and transferred. We now have increasing numbers of women coming in to freeze their eggs, as they are not yet ready to have children. Egg freezing offers some insurance against the loss of fertility that occurs with age. As embryos can be frozen indefinitely with little or no loss of viability, some people call this freezing time. What are the negatives of freezing embryos? The process of freezing will not make a normal embryo abnormal, but there is a small chance that any given embryo will not survive the freeze-thaw process. Over 90% of embryos do typically survive thawing, but for any given embryo, the survival rate can be anything from 0 to 100%. The other downside to cryopreserving excess embryos is that freezing and storage charges are usually not covered by insurance, so this would typically involve an additional charge. Freezing embryos and going through a subsequent FET cycle is much less expensive than another fresh IVF cycle, but the financial staff can discuss all of the details with you and give you all of the information you need depending upon your particular insurance plan. Because the embryos are created outside of the body with IVF, we can remove or biopsy some cells from each embryo and perform genetic testing on them. With regular IVF, we typically watch the embryos develop to day 5 and then transfer back the embryo or embryos that look the best. However, we know that the appearance does not indicate whether it is a normal embryo. With pre-implantation genetic testing, the embryos are biopsied on day 5 to 6, and several cells are removed from each one. The embryos are then frozen, and the samples are sent to an outside laboratory for genetic analysis. There are 3 types of genetic testing that can be performed. The first, pre-implantation genetic testing for aneuploidy, or PGT-A, determines how many chromosomes are in each embryo. As we mentioned before, a normal embryo should have 46 chromosomes, 23 each from the egg and the sperm. This embryo is euploid, meaning it has the correct number of chromosomes. In almost all cases, any number other than 46, a condition known as aneuploidy, either results in no pregnancy or a pregnancy with a subsequent miscarriage. So by transferring only a euploid embryo, we can significantly increase the chance of pregnancy and decrease the risk of miscarriage. The other 2 types of testing, pre-implantation genetic testing for monosomic disorders, PGT-M, and pre-implantation genetic testing for structural rearrangements or translocation, PGT-SR, are performed to determine if the embryos carry specific known genetic mutations, like sickle cell anemia or cystic fibrosis. This procedure is performed if a couple is already known to be at increased risk for passing along a specific disorder, and they can then try to avoid passing that disease onto their child. This video demonstrates how the embryo biopsy is performed. The trophectoderm cells are found around the periphery of the embryo at the blastocyst stage, typically 5 to 7 days of embryo development. These cells are destined to become the placenta and other tissues that support the pregnancy, but they do not become the baby itself. The embryologist biopsies or removes some of these cells, which are then sent to the lab for analysis. The cells are secured with gentle suction and placed under traction. Laser pulses are then applied to the cells to separate them from the rest of the embryo. These cells are sent to an outside lab for analysis, while the embryos themselves are frozen in our lab. Your embryos never leave our office. It is only the cells that are shipped out. Once the cells are tested, we receive a detailed report that your doctor will review with you. Why does PGT-A increase the pregnancy rate? We know that egg quality declines as a woman ages, and studies have shown that already at age 30, a large percentage of embryos are aneuploid or have the wrong number of chromosomes. The proportion of aneuploid embryos is around 50% up until age 38, and it then increases beyond that until the early to mid-40s when around 75% of embryos are abnormal. This does not mean that you don't have any normal embryos left, but if we only have 2 or 3 embryos after a woman undergoes IVF, the chance of 1 or even none of them being normal increases significantly as she ages. If PGT-A is performed and shows that you have at least 1 normal embryo, the chance of pregnancy goes up while the risk of miscarriage goes down. This happens because the majority of first trimester miscarriages are due to fetal aneuploidy. PGT-A also significantly decreases the risk of having an abnormal amniocentesis and then having to decide whether to terminate the pregnancy. With traditional IVF without PGT-A, the success rate depends upon the patient's age and ranges from a high of around 50% for patients under 35 to a low of 14% or less in patients 41 and older. This is a direct reflection of the percentage of abnormal embryos at older ages. If PGT-A is performed and you have a normal embryo, the chance of pregnancy is around 45 to 60% regardless of age. It is more difficult to get a normal embryo at an older age, but once we have a euploid embryo in a 42-year-old, her chances of success would be close to 60% as well. Without PGT-A, we typically recommend transferring 2 embryos to give a good chance of pregnancy, but this also results in a 27% risk of twins. If you have a euploid embryo after PGT-A, the chance of pregnancy is high enough that we can only transfer one embryo at a time. This is known as elective single embryo transfer, or ESET, in which case the chance of twins drops to 1 to 2%. As women age, in addition to a lower pregnancy rate, there is also a greater chance of miscarriage or pregnancy loss after conception, even with IVF. This risk is usually 10 to 20% for women under 40 and up to 50% for women aged 40 and older. The risk of miscarriage is a significant factor in lowering the ultimate healthy baby rate after IVF. With PGTA and a normal euploid embryo, the risk of miscarriage drops to 6 to 7% or less. The report we receive also tells us whether each embryo is male or female, so if you have one of each gender and wish to decide which one to transfer, that can be an option. Some couples do not want to know the gender of the embryos we're transferring, so we will only share this information with you if you choose to know. So why would a couple not opt to do PGTA? PGTA is a very powerful tool, but not 100% reliable. It is only 95% accurate. So we do still recommend undergoing standard prenatal screening once you are pregnant. PGTA involves embryo biopsy, which in rare cases may damage an embryo. Since we cannot get the results from the testing back in time to do a fresh embryo transfer, this testing requires freezing the embryos and then undergoing a frozen embryo transfer in a subsequent cycle. This can usually be performed the very next month, as long as we have a normal embryo to transfer. Keep in mind also that this testing looks for very specific things, either the number of chromosomes or a single genetic disorder. It does not detect all birth defects or all genetic diseases. It will, however, determine the presence of something like Down syndrome, which involves an extra chromosome 21. Finally, while insurances may cover PGT-M or PGT-SR to test for specific genetic disorders, PGT-A for general aneuploidy screening is usually not covered by insurance, even if you do have IVF benefits. The approximate cost of the embryo biopsy and the genetic laboratory testing is around $3,000 to $4,000, depending upon how many embryos you have to biopsy. If you have several extra embryos to freeze from your cycle, it is nice to know that they are genetically normal before you pay storage charges for them, possibly for several years, if you become pregnant after your first embryo transfer, until you ultimately decide to use them. You will never be as young and your eggs will never be as good as they are now. If you choose to do PGTA, the best case scenario is to undergo 1 or 2 cycles of IVF and get all of the euploid embryos you will ever need to build your future family. In this event, you would not have to go through IVF again and instead would only have to do an FET cycle each time you wanted to conceive. PGTA is an option for all patients to consider carefully, weighing the pros and cons. There are certain people for whom we strongly recommend pre-implantation genetic testing. Patients at risk of passing on a specific genetic disorder should strongly consider PGT-M or PGT-SR. If patients have suffered recurrent miscarriages and testing has not revealed another cause, it is very possible that the pregnancy losses were due to aneuploidy. We thus recommend IVF with PGTA not only to increase the chance of pregnancy, but also to minimize the risk of experiencing yet another devastating miscarriage. Finally, for those patients who only want to transfer a single embryo, known as elective single embryo transfer, PGTA should be considered so that we can be sure that we are selecting a normal embryo. This is typically advised for patients who need or want to avoid twins for medical, personal, or safety reasons. So now you've gone through the entire IVF process, with or without genetic testing, and your pregnancy test is hopefully positive. At that point, you will be given very specific instructions on which medications to take and when to return. We follow the pregnancy hormones and progesterone levels very closely, and you will have your first ultrasound at the equivalent of 6 weeks gestation, which falls about 2 weeks after your first pregnancy test. This first ultrasound is to confirm that the pregnancy is in the correct location and to see if it is only one or more than one baby. The ultrasound may be repeated as necessary, and ultimately you will have one last visit and ultrasound with your specific doctor around 8 weeks. This is known as your OB exit. After that, you graduate from the practice and will follow up with your obstetrician starting at around 9 to 10 weeks of gestation. If the first cycle of IVF is not successful, it is certainly very disappointing. Even with a chromosomally normal embryo, the chance of success is not 100%. So unfortunately, there will be those who are not pregnant after their first IVF cycle. If you are in this group, do not despair. We learn a lot from unsuccessful or canceled IVF cycles so that we can optimize your next cycle. If you are not pregnant after your cycle, you will be instructed to stop all of your medications and to anticipate a menstrual period. Our physicians meet once a week to discuss all of the IVF cycles that were unsuccessful and to analyze every aspect of the cycle, from the stimulation protocol and the dose of medication to the number of eggs retrieved and the embryo development. We all put our heads together to make recommendations for the next cycle based on what we've learned. You should schedule an office visit with your doctor 2 weeks after your negative pregnancy test to discuss our findings and recommendations. Sometimes we conclude that you might do better with a different stimulation protocol or a higher or lower medication dose. Or sometimes we review a cycle and find that everything went very well. It was just bad luck that you did not get pregnant, so we don't recommend changing anything for the next cycle. Even if you do not plan to do another cycle anytime in the near future, we still strongly urge you to attend this follow-up visit. Success improves with second and third IVF cycles, as you can see here. If we assume you are in an age group with about a 50% chance of success, after one cycle, half of all patients are pregnant and half are not. After a second cycle, another 50% of the remaining 50 patients are pregnant, so now 75 out of the original 100 couples are pregnant. After 3 cycles, 88% of all patients who started the process are pregnant. These numbers explain why the national average is 2 to 3 cycles to have a baby, but we certainly hope you are in the first group. The most important thing is to stay positive. Thank you for your attention and for choosing URA to help you build your family. We hope this orientation provided you with a better understanding of the IVF process. If you have any remaining questions, please write them down and discuss them with your doctor at your IVF Go visit. If you have already attended your Go visit but have some additional questions after seeing this presentation, please feel free to contact our office and speak to your doctor or nurse. Thank you, and we wish you the best of luck.